Hello everybody, my name is Aleksandar Celebic and I came from Podgorica, from Montenegro, from National Institute of Oncology. Thank you, Dr. Vasileva, for inviting me to this excellent event. And thanks to you, Professor Agius Kalea, for guiding this magnificent GYNOCARE action for a couple of years. I hope to collaborate with all of you in next years. As Mariella told, I will be focusing on challenges in the implementation of sentinel lymph node biopsy in situations with limited resources, like ours are. I'm not quite sure about Bulgaria, but Montenegro definitely. And I'm very happy because previous colleague explained us in a very clear manner how the sentinel is managed in Bulgaria. And I'm also very happy that previous discutant estimated Professor Rutgers told us that today, if I understood well, is a decreasing, let's say, motivation trend towards radionuclide sentinel lymph node biopsy, and that we are going towards, let's say, different tracers that are not connected with radioactivity. Not only because of radioactivity, but because of the complex organization, agenda, and etc. So, first of all, I would like to say that, to recall, actually, that the recurrence and survival rates of breast cancer largely depends on the involvement of the axillary lymph node. Axillary lymph node dissection was previously identified as the standard axillary treatment for breast cancers for many years, as we saw from previous presentation. However, axillary dissection-induced complications are very common. So, like axillary lymphedema, limited activities, numbness, stiffness, seroma formation, and the risk of vascular and brachial plexus injury, which also exists. Lately, axillary lymph node dissection for early breast cancer patients with clinically negative lymph nodes did not further improve the survival rates, but patients still experienced unnecessary postoperative complications. So, breast sentinel lymph nodes is the first sentinel node to drainage from the breast and has the highest probability of being affected by cancer cells. So if sentinel exhibits no metastasis, the probability of axillary lymph node metastasis is very low. Clearly displayed sentinel lymph nodes are of utmost ideal for surgeon during surgery, and with the use of ideal tracers and identification methods, lymphatic vessels and sentinel can be clearly displayed during surgery. So, sentinel nodes lymph biopsy was first reported by Morton in cutaneous melanoma in 90s. Then the concept was very soon adopted by breast surgeons in breast cancer patients. And then it became a standard procedure for axillary staging in early breast cancer. As a minimally invasive surgery, sentinel can accurately stage the axilla and leads to less morbidity than axillary lymph node dissection. The mapping method is one of the most important factors affecting the identification rate and false negative rate, which represents the most important outcomes of sentinel nodes. Giuliano conducted intraoperative lymphatic mapping and identified the sentinel nodes using only blue dye. Then Craig investigated use of radioisotopes, and finally Albertini was the first to identify the sentinel nodes using a combination of two methods. The objective of this talk is to give, first of all, one narrative landscape of a different common tracers used for sentinel lymph nodes, then to elaborate on challenges in situation with limited resources, and to initiate the last but not the least, to initiate an investigation screening inside GYNOCARE consortium in order to give an insight on different methodologies used in different GYNOCARE countries to identify sentinel lymph nodes in gynecological tumors, and particularly including breast cancers. So we will start with the first goal. The traditional tracers method of sentinel lymph nodes, as previous elaborators told us, is dye method, radionuclide tracer method, and the combination. And some new tracers methodologies are produced continuously, such as nanocarbon suspension, contrast-enhanced ultrasound tracer, indocyanin green fluorescence, superparamagnetic iron oxy tracer, microbubbles, and more. So radionuclide tracer, their advantage is that is very clear preoperative positionment, strong surgical pertinence, small damage. The detection rate is very high, and the false negative rate is quite fair or low. Disadvantage is because there is a radioactive contamination. The patient has obvious pain during preoperative injection. The operation process is complex, the price is high, the corresponding instruments and equipment are needed, and there is needed a collaboration between all the stakeholders participating in this process. Then we have a dye method in a combination with the radionuclide method, which has a high sentinel lymph node detection rate, but still the procedure combination is complex, requires a need of cooperation, the high cost and difficult to popularize such a method. Blue dye, let's say that constraints of radioisotopes have led to the development of non-radioactive alternative methods, and the first one is dye method, which is easy to operate and to obtain. It has a low molecular weight, strong bindings to tissue protein, and simple operation. Also, it is just injection 10 to 30 minutes prior to operation without special equipment and is very low price. The methylene blue alone method has gained popularity worldwide, particularly in developing countries with low resources, because it is cheaper than isosulfan blue, easier to obtain in developing countries as well. And last but not the least, such as life-threatening anaphylaxis and international shortage, it is not comparable with other blue dyes. Let's say that there is a range of different references, different papers, meta-analysis, for example, and majority of them are Asian authors, logically because they use a lot other than radioisotope tracers. So, for example, this one with approximately 1,600 patients from 18 studies from 12 different countries, it was one of the first systematic reviews to provide an overview on the, let's say, feasibility and accuracy of sentinel lymph node mapped with methylene blue dye alone. So the identification rate was very high, 91%, and the false negative rate was only 13%. I said only. We will see that according to American Society of Breast Surgeons, they recommend at least 85% of identification rate and as low as only 5% or less of false negative results. So based on this, let's say it is acceptable, let's say identification rate from this meta-analysis, but higher, a bit higher, let's say false negative rate of 13%. So the caution is warranted when using methylene blue alone as the mapping method. We will see later what are the tips, how we will increase the identification rate and decrease the false negative rates. In another study, also PASEX meta-analysis, which included 183 studies, the overall false negative rate was 7.5%, and in the subgroup analysis was for only blue dye was as low as 8.6%. Factors associated with the false negative rates of sentinel and how to decrease it. There are some tips. For example, to use it, let's say, in a smaller tumor volume, that use a little bit increased number of sentinel lymph nodes, and of course that the procedure is conducted by experienced surgeon. And of course, there are some strategies for decreasing false negative rates, attempting to identify more sentinel lymph nodes, removing any hard or large nodes besides adjacent to a sentinel node, selecting an experienced surgeon, and of course selecting patients with smaller tumors. There are some tips for us who are coming from low resources countries. We do have also, in spite of the fact that the majority of these analyses and papers were published by Asian authors, here we do have a very interesting examples from Western European countries, for example, from Liège in Belgium. One team guided by I think Andreani, Fabrizio, and others. They have used technetium for many years in 1990s, and then they switched to patent blue dye, and it is the only tracer from the January 2000. Of course, their conclusions and their practice is based on their retrospective study that is organized by them, which revealed the comparable results of the blue dye alone and radioactive tracer or dual method of mapping without the need of special equipment and additional personnel. I think this is some kind of decreasing tendency of use of radioactive tracers in the Western world. Now the indocyanine or ICG, I will not spend a lot of time because previous colleague explained in an excellent manner. So just to say that there is a lot of advantages. For example, there are abundant lymphatic in the areolar area, and injecting the tracer in this area may result in higher identification rate. Then it is safely injected intradermally or subcutaneously, and it is absorbed very quickly. And tattoo-like lesions, which are obviously very frequently seen by methylene blue, are not seen very frequently with ICG. And finally, but not the least, ICG can move through subcutaneous lymphatics in 1 to 3 minutes. Then we do have another advantages of ICG, for example, that can penetrate only 1 centimeter thick tissue. It is possible to observe the whole process of the spreading of this tracer moving into the axilla. Fluorescence guiding sentinel lymph node can achieve real-time imaging as well as direct visualization. This enables easy learning, accumulation of experience and learning curve. And finally, the complications are very rarely reported. There are several studies supporting this idea of ICG. Many of them findings, of course, with superiority of fluorescence method by ICG. Here we do see different methods. In this study, triple tracer method has been used. We see different points of injection of methylene blue, ICG, and radioactive tracer. On this picture, we see correlated data, correlated identification by two methods, by ICG and radioactive tracer. And on the upper, it is the image C. We see 3 lymph nodes, sentinel lymph nodes, and the first one is colored by methylene blue. So this is, we also have a recent meta-analysis of Asian authors with 30 publications and more, with 4,000 sentinel lymph nodes. There is ICG had better detection rate than blue dye. Insignificant difference comparing to radiocolloid tracer, and there is ICG can be considered to replace actual methods. Of course, we do have a range of different meta-analyses, all of them showing the superiority of ICG methods. And finally, but not the least, just to say that ICG and methylene blue as a combination has a major advantages. For example, can detect more metastatic sentinel lymph nodes, is of extremely high sensitivity to find some sentinel lymph nodes that are undetected by methylene blue, and also it can be considered, based on all of these results, as a good replacement, particularly in countries with low resources. Here we do see double tracer utilization with ICG and methylene blue. On the B, we do have 6 different nodes seen on sentinel lymph nodes seen on ICG, and then we do have 4 that are, let's say, colored by methyl and blue, showing that ICG is even more performant method with better outcomes comparing to methyl and blue. Then we do have some less, let's say, exploitable models like contrast-enhanced ultrasound tracer. We do have nanocarbon suspension, which particularly are used in China. Their advantages is that there are small dosage and fast absorption by lymphoid tissue, accurate localization, strong staining, specificity. They are of a moderate price, and of course they are safe and non-toxic. Also, there is a super paramagnetic iron oxide, also one in development method, which use injecting a magnetic tracer which migrates through lymph vessels into the sentinel lymph node. Their advantages is does not require nuclear medicine department. The detection rate of sentinel lymph nodes is similar to that of radionuclides, and meta-analysis confirmed its non-inferiority comparing to all previous methodologies. Disadvantages, of course, there is a little bit higher false negative rate. It has a significantly higher lymph node retrieval rate comparing to other methodologies. The intramammary persistence of the magnetic tracer can interfere with the results of magnetic resonance in postoperative follow-up periods. And then the magnetic field generated by magnetometer can be interfering with cardiac patients with let's say, heart rhythm, with pacemakers, so it is not useful for them. Microbubbles is also one innovative technique, contains sulfur hexafluoride gas and acts as sonographic contrast agent. It is inaugurated in 2004. There are different advantages of this. Real-time visualization, contrast agent is very cheap, and of course it prevents patients from allergy. Disadvantages is because it is very slower compared to others, require proficiency of axillary ultrasound examination, has a longer learning curve, and of course is a lower sensitivity. Now we go to the second part. It is to elaborate on challenges in situations with limited resources, and it is in a bit conclusions of all what did we say. So the traditional tracer methods include dye method, radionuclide tracer method, and dye combined radionuclide method. As being elaborated, the radionuclide tracer has many limitations. Two the most widely used alternative tracers are methylene blue and ICG. Methylene blue is cheaper, is easier to obtain in developing countries, and also methylene blue does not have the restrictions in terms of life-threatening anaphylaxis or international shortage. Sentinel lymph node mapped with methylene blue dye alone result in acceptable identification rate from 91 to 95%, but a bit higher false negative rate, 6 to 13%, and therefore a caution is warranted when using the methylene blue dye alone. Then it is mandatory to conduct the effective strategies for decreasing the rate of false negative sentinels that I elaborated previously, and methylene blue can be safe, simple, and cost-effective technique, particularly in countries with limited resources. ICG also have a high identification rate, accurate diagnostic performance, may eventually replace the traditional application of blue staining and radioactive agents, so is becoming more and more popular. And conclusively, ICG is additional method or a replacement method, and our proposal would be that surgical technique and operative detail must be standardized, and surgeons should be familiarized with it. And finally, ICG with methylene blue, the high identification rate has been detected with accurate diagnostic performance and highly preferred non-radioactive alternative method for dual tracing sentinel lymph node. Finally, just two last slides is about the last objective, and this is to involve all of us inside the GYNOCARE consortium. This is to initiate an investigation or screening inside GYNOCARE group in order to give an insight on different methodologies used in different GYNOCARE countries to identify sentinel lymph node in gynecological tumor, including breast cancers. And thanking this initiative is thanking to this excellent event organized by Mariella and colleagues. So in following days, let's expect a detailed screener or questionnaire will be sent to all GYNOCARE stakeholders involved in surgical departments in both developed and developing countries inside the consortium in order to collect information on their surgical practices concerning tracers used in detection of sentinel lymph nodes. This attempt is with aim to make a landscape or panorama of surgical practices in minimally invasive approach in surgical oncology, and I hope will result in creating some kind of published GYNOCARE recommendation for sentinel lymph node practices, especially in situations with limited resources. Of course, I'm open to further consultation and your insights and count on your kind collaboration on this topic. And I thank you for your attention.